welcome to the CareCentrix AHIP Institute video series. My name is Dr. Mike Cantor. I'm the Chief Medical Officer with CareCentrix, and joining me for this discussion of artificial intelligence and analytics is Anita Pramoda.
Thank you for having me, Dr. Cantor.
Thank you for joining me this afternoon. We'll briefly introduce ourselves and then get into some interesting questions about how we use information to help people stay home and heal and to understand where the opportunities are to improve that process. So first, a little about me. I'm a geriatrician and a lawyer by background, and I've been with CareCentrix for a couple of years, and I'm really proud to be part of an organization helping to bring more care to the patients rather than bringing patients to the care. Share with us a little bit about yourself.
Awesome. My name is Anita Pramoda. I'm an engineer by training. I started and I'm responsible for this company called Owned Outcomes. We predict events, adverse events that are, so that one, we understand that these events are going to happen. Two, we can isolate computationally the drivers of these events. And then three, we can filter which ones of those are addressable. And then four, we can partner with various customers to turn them into useful outcomes for the patient. So that's what we do, and excited to be here with you.
Great, great. Let's talk a little bit about artificial intelligence and analytics. Artificial intelligence is one of those buzzwords that everyone seems compelled, along with the term machine learning, whatever that means, to add to their products in order to make them appear attractive. But in your mind, what is the ability of artificial intelligence? Can you explain how that works to really improve access to care, understanding how people are going to heal or what adverse events they might face when transitioning home from a hospital or a rehab setting?
So your comments are very fair. Where we have enough data, we have a starting point. Where the data is clean, we have an even better starting point. And where models are today and where models do well is in classification problems. You know, is there going to be an adverse event or is there not going to be an adverse event, right? Now there is there is often a push and pull between the efficacy of a model, as in how accurate is a model, and the explainability of a model, which is why is a model telling us what it's telling us. And the explainability is still evolving as we speak. And that a certain level of explainability and transparency is very important for us in healthcare to be able to share that with clinicians and put it into mainstream use, and that's where we're inching forward. An example of where we've done very well is the ability to predict readmissions and adverse events post-hospitalizations. We've been able to isolate what sites of care, what units of care, and what types of interventions will help a patient avoid such adverse events, right? And those are often extremely addressable problems. Sometimes they're social in nature. Obviously, some of those are clinical in nature. Some of them are behavioral in nature, and we've been able to isolate those. And those are live today, and we've had a lot of success with them in reducing readmissions as well as letting patients stay and heal and ultimately thrive at home and in the community.
Great. Yeah, we're lucky at CareCentrix to use some of your tools, and I know that they're really helpful for patients who are in the hospital trying to figure out what's the right place for me to go next. Do I need to go to a skilled nursing facility, or can I just go home? And if I do go home and need a home health agency to help me, which one is the best one for me? Because each patient has a unique set of needs, a unique environment in terms of what their home situation is like, their family support, and all the rest of it. One thing that's interesting is that you've done some data analytics recently for us, looking at the correlations between how quickly people get to home health services and what the risks are of either having a high cost episode or being readmitted to the hospital. Can you share with us a bit about those findings?
Sure. You know, actually one of the best ones that comes to mind is we looked recently at a cohort of more than 20,000 Medicare patients within the last couple of years that had recently undergone a major joint replacement. And what we found, this specific cohort is a female patient cohort up there in age, and what we found was a 75% or 0.75 correlation between how quickly they received home health after discharge and their propensity for readmission. And what then that translated to is more than a $4,000 cost differential on a per episode basis. So this is definitely, so to get people home health in time, to be responsive to patients and get them help as quickly as possible, can one, help the patient be more successful and get better, but also be financially, materially impactful in bending that cost curve. We've seen similar patterns in heart failure, we've seen similar patterns in sepsis. So if you look at the top five states where there are sepsis patients, the curve is literally a straight line in terms of the longer you take, the more expensive the patient episode of care gets.
Very interesting. And in terms of barriers to home health, what else are you finding? Certainly the speed of deploying home health people into the home, nurses or therapists, home health aides matters. What other things have you uncovered in terms of understanding what the barriers are for patients getting the home health that they need?
There's a number of reasons, there's a number of barriers that patients experience, right? So everything from their benefit design's not quite right, to they don't understand whether the home is the right side of care, if they'll get all the help they need. Maybe they live in a rural area and there's access issues. But then I'll talk about the ones that I'll talk a little bit more about the ones that are addressable by technology, right? So I think of three vectors of utility when I think about how technology can help with some of the barriers in home health. The first one I think about is a logistical vector, right? So to ask the question, of all the patients I need to help today, which ones do I need to prioritize and why? Then another example would be, of all the methods in which I could offer a touch point to a given patient, what is the most efficient way to touch them? So some patients may respond well, you could get the same amount of efficacy or influence with a phone call. Some others may need a video visit. Some others you may have to visit in person and help them out, right? And then another example of that logistical vector will be, and if I must visit them in person, this queuing theory, there's so many well understood operations research principles that have been applied in supply chain. I mean, for example, we really know how to move a box of tissue from warehouse A to warehouse B super efficiently. You can apply a lot of that mathematics to corralling the people and the resources a patient needs at the right time to their house in the most cost efficient way. So that to me is some of the examples and how I would tackle the logistical problems in home health. Another vector that I think about a lot is what I think of as the informational vector, right? Informational. So when a patient is home, or I don't care where they are, when a patient is sick, there's a huge information asymmetry between them and their clinician in terms of their circumstance. That makes them feel vulnerable, makes them feel nervous, that makes them feel helpless sometimes. And so we could use technology as a very efficient mechanism to give them the right information at the right time in a format that's consumable to them. So that's the flip side of that is true as well, right? Which is, from a clinician's perspective, as a human race, we've managed to create information at a dizzying pace, and that pace surpasses our own ability to cognitively ingest it. And so there is an opportunity for technology to help our clinicians be up to date on something that's most relevant and evidence-based. Because ultimately, the tyranny of information is such that there is volume, there is variety in the data, there is variability in the data, there's just every form of complexity associated with the data. And maybe another example I'll give you as I think about the informational vector utility is if we can present trade-offs to patients using technology, if we can succinctly present trade-offs and the consequences to patient with some amount of computational support, then we can enable them in shared decision-making mode, right? So then they're much more invested, and there's plenty of evidence to shared decisions lead to ownership, leads to adherence, leads to better outcomes and all of that. So the third dimension is one that I think we're hearing a lot of colleagues talk about, including at this conference, which is the care pathway vector. And that's where we started this conversation, which is, how can we use information to know what the next site of care is? What is the most optimal number of units of care? Do they need 9 visits from a home health nurse or 10, right? Being much more precise, understanding the patient's circumstance, including ones that they may feel somewhat embarrassed. There might be a social stigma associated with expressing certain needs that we could have discovered and validated with the patient because we were informationally equipped, right? We could, there's often a statistic around, is it 7 times the likelihood if someone's someone's disposition for depression is about 7 times higher when they have a chronic disease. So to the extent, we are more thorough about our information collection and understanding of a patient, then we can understand that entire whole person's circumstance better. So, so there's a number of these inputs that we can efficiently take and throw silicon at that problem to crunch all of that and ultimately tailor the care plan to that patient and be more precise in taking care of that patient in their entirety of their life. So those are the opportunities that I see for technology.
Yeah, so to summarize then, it's really, the barriers are, we have a hard time getting people what they need where they need it. So that's the logistical kind of approach.
Mm-hmm.
A second one is there's sort of an asymmetry of information between clinicians and patients.
Mm-hmm.
So in being able to really help patients learn what they need in the way they can understand, because sometimes clinicians aren't great about speaking the language, literally or figuratively, of their patients, but also helping the physicians and the clinicians, nurses and others take advantage of this massive growth in medical information. I think that the medical knowledge doubles now every 6 months or something like that. There's no way any human can keep track of all of that. So it's really addressing the information asymmetry the clinicians face as well as the patients. Then finally, it's sort of how do we predict what someone really needs given their totality of, you mentioned, behavioral health, depression diagnoses, certainly physical health diagnoses. I think you guys have also done some interesting work recently with more of the so-called social determinants of health as well. Can you explain a bit more about what you're doing in that area?
We are actually doing that together. In Connecticut, for example, we understand we understand food deserts. We understand access to transportation lines. We understand people's automobile ownership, right? And therefore, then their need for public transportation, and a whole bunch of other, including language barriers that they may have, their literacy levels, to see how should information be packaged and relate to them such that they'll be able to ingest it and be able to act on it and feel empowered by it as opposed to fall under the weight of it, right? And we're able to then bubble up the effect sizes of each one of these and find out which ones are the most easy to address and may have the greatest efficacy on the patient's, the patient's progression path, if you will. So this is live. We've been working together in Connecticut for many, many months now and have some positive results because now we're able to address the patient as a whole in totality as opposed to just address a sliver of their life, which is their illness.
I've heard it said that a person's zip code is more important than their genetic code when it comes to their overall level of health. Are you finding that to be true? I'm just curious in the work that we're doing together.
For sure. In fact, we have found, this is still preliminary studies, but we're finding that about 60% of their disease progression or healing progression is driven by their zip code as opposed to their medical situation.
60%?
North of 60%.
Wow.
That's a scary number.
Wow.
But that's also a call to action on our part, right?
Right.
So now that we have computational support to know that, and if we can learn it on each and every individual patient basis on an N=1 basis, we have an opportunity to move the needle for real.
Absolutely. Is there anything that you think we haven't covered in terms of an area, maybe it's related to analytics, maybe not, where you feel like if we could change that, we could really move the cause of home health and of course patient health forward?
So one of the things that I've been intrigued by, I often worry about what is addressable by technology versus what's not, because technology has so much power, but it also has so many limitations, right? And one of the things that I'm very curious about is how can we be more culturally competent given how non-homogeneous our society is? How can we be more culturally competent in approaching and addressing our patients' needs such that then we're more tailored in our approach and ultimately can appeal to the most personal of needs in a manner that understands them and we start from them as opposed to starting from us. So I'm very curious to see what the thoughts that bubble up on that front are.
Okay, no, I agree. There's a lot of opportunity beyond the tech piece. I always think about how improving the quality of care that patients get, the people get, requires technology and people. And so if you don't have the right people with the right training or knowledge, or if you don't have the right technology to support them, whether it's sharing information through electronic medical records or doing the analytics to understand which of your patients are at risk and what they're at risk for. They're two parts of the same whole, and if you don't shape both parts together, you often end up with a mess, which is kind of, I think where we are in a lot of parts of our healthcare system, and in home health, which is less, like you talked about the information gap when people leave the hospital. It's pretty typical, like the quality, we understand the quality of what happens in a hospital, even in a clinic setting, way more because we actually have way more observations of what's happening in those settings. For home health, it's a little more of an information desert almost in terms of what we're learning. So I think you're right to think about it not just as technology alone, but the combination of services or people with technology that really makes a big difference.
I'm optimistic.
Yeah.
I'm certainly optimistic. There is an information collection problem. There's an information, and then there's a problem around harvesting the signals that matter,
Right.
and then there is a matching problem. 3 problems that you alluded to. But I do think we have a real opportunity now, to the extent we are willing to be. The opportunity and the challenge when we go home is the universe is much bigger. So
Exactly.
our aperture needs to get wider, right?
That's right. That's right.
Therein lies the opportunity, and therein lies our challenge.
That's right. Well, thank you so much for being with us today. I really appreciate your thoughtful approach to understanding how analytics and technology can really help us improve care of patients at home.
Awesome. Thank you for having me.
My pleasure. Thank you.